Ruptured cerebral aneurysms produce subarachnoid hemorrhage, which might have devastating complications and devastating effects. Earlier, these patients were managed conservatively, aiming just to prevent the rebleed. Then the neurosurgeons developed, especially Dr. Yasagil, Professor Yasagil and his group, developed large series on aneurysm clippings, though even Cushing and Dandy have contemplated aneurysm clippings and done also aneurysm. The advent of endovascular interventions to obliterate aneurysms by using detachable coils changed the paradigms. Clipping is restricted to few aneurysms and to some complex aneurysms where coiling is not feasible. However, neurosurgical training revolving around aneurysm clipping provided an excellent in-depth hands-on training for residents, which is now slowly getting eroded because of the dominance of endovascular approaches. A quick overview of the anatomy of the circle of Willis. The internal carotid arteries enter the cranium through the carotid foramen, traverse the cavernous sinus, and pass intradurally through the dural ring. The first intradural branch is the ophthalmic branch, which goes to the eye. And at this point, you can have an aneurysm, which is the ophthalmic aneurysm. The next branch, prominent branch, is the posterior communicating. The posterior communicating artery connects the ICA with the PCA, part of the circle of Willis. So at the origin of the PCOM, you have PCOM aneurysms. ICA moves further up. You also have anterior clinoidal aneurysms just next to the PCOM, often difficult to differentiate, but with more devastating complications. The ICA passes back and then bifurcates into the middle cerebral artery and the anterior cerebral artery. And at this bifurcation again, you can have an aneurysm which is called an ICA, or internal carotid artery bifurcation aneurysm. The middle cerebral artery supplies the lateral aspect of the cerebral hemisphere. It divides into temporal and frontal branches and sometimes into a trifurcation. And at the MCA bifurcation or trifurcation, you can have an MCA bifurcation or trifurcation aneurysm. The anterior cerebral arteries come together in the interhemispheric fissure region and then ascend over the corpus callosum as the A2s. And at the point where the ACA turns into the A2 or the second segment of anterior cerebral, you have communicating artery which connects both the ACAs together to and complete the anterior part of the circle of Willis. So here also you can have aneurysms which are called the ACOM or anterior communicating artery aneurysms. The ACA as it moves up can have aneurysms again called distal ACA aneurysms. Posterior circulation aneurysms are aneurysms which originate from the vertebro-basilar circulation. The two vertebral arteries ascend through the foramina of the vertebra and then enter the foramen magnum. They pass anterior to the brainstem and unite to form the basilar artery. This basilar artery, the vertebral arteries themselves give rise to branches, the main branch being the pica or the posterior inferior cerebellar artery. And at this point, you can have a pica aneurysm. The two vertebrals unite to form the basilar. The basilar gives off the ICA or the anterior inferior cerebellar artery and then moves up and gives the superior cerebellar arteries. before bifurcating into two posterior cerebral arteries. These posterior cerebral arteries arch over the tentorium to supply the thalamus and the occipital lobe. Connection between the ICA and the PCA is the pecon. And at the top of the basilar or at the branches, the ICA and the superior cerebral artery, you again have aneurysms. ICA aneurysms, SCA aneurysms, and tip of the basilar, basilar tip aneurysms. Two factors contribute to aneurysm formation. One is the flow dynamics. The flow of blood impinges at the bifurcation, producing a bulge. The second is what contributes to aneurysm formation is medial defects in the muscularis layer, which allow the intima and the serosa to bulge out. Aneurysms are present, cerebral aneurysms are present in a whole lot of people. Up to 2% of the population may have intracranial aneurysms which are undetected. They produce symptoms when aneurysms rupture, producing subarachnoid hemorrhage. The clinical presentation is classical, sudden onset severe headache, which is called a thunderbolt headache because of the suddenness and the severity. In some cases, before the actual thunderbolt, patient might have episodes of minor headaches, which are described as sentinel bleeds or herald bleeds. That is, a small bleed has occurred, which is probably ignored because the headache was not severe. A major subarachnoid hemorrhage is associated with nuchal pain, often producing a diagnostic dilemma with meningitis. Depending upon the severity of the SH, you can have impairment of consciousness. You can also have neurological deficits, which can be motor or cranial nerve. The classical cranial nerve involvement in an aneurysm, which might not even have ruptured, occurs with the laterally pointing posterior communicating artery aneurysm, which impinges upon the third nerve. The severity, clinical severity of aneurysm bleeds is graded by the Hunt and Hess grading. Grade 1 to 3 are favorable, and grade 4 and grade 5 have poor prognosis. Fisher grades are a radiological grade of severity. When a patient presents with a clinical profile of subarachnoid hemorrhage, the investigations which are done are firstly a CT scan. CT scan will show basal subarachnoid hemorrhage. A CT angio will then demonstrate aneurysm anatomy. And a digital subtraction, a catheter angiography using the DSA technique, will show us the anatomy in more detail and also flow patterns, and will help us to see smaller perforators which are not seen on a CT angio. The neurological consequences of aneurysmal subarachnoid hemorrhage are grievous. The primary insult itself may be so severe that death may occur before the patient reaches the hospital. And adverse outcomes are present in up to 50% of aneurysm bleeds. The second is after the patient reaches the hospital, there might be a rebleed, which is associated with a very high mortality, more than 75%. The third is a phenomenon not fully understood. You have a primary protective spasm which stops the bleed, and a delayed spasm which occurs between day 4 and day 21. This kind of vasospasm, which affects not just the vessel segment where aneurysm is split, but also the branches, may result in delayed ischemic neurological deficits, worsening the outcome. Seizures can occur. Electrolyte derangements ranging from diabetes insipidus, syndrome of inappropriate ADH secretion, and cerebral salt wasting may occur. And hydrocephalus is common, especially when there is intraventricular bleed, resulting in a blockage of the CSF drainage pathway. There are certain skills which are necessary for a neurosurgeon venturing to clip an aneurysm. The surgical approach for most anterior cerebral artery aneurysms, and even for a high riding basilar top aneurysm, is through the pterional approach. It is actually really a skull base approach where the sphenoidal ridge is drilled flat so that the circle of Willis can be accessed without too much of brain retraction. And this provides you an opportunity to get proximal control, which we will be coming to later. The second important skill is a Sylvian fissure split, opening the Sylvian fissure, separating the frontal and the temporal lobes, allows us to retract the frontal lobe to facilitate access to the circle of Willis. The third is a brain which is blurred is a brain which is tense. So this tension can be reduced by CSF drainage. It can be done intraoperatively by draining CSF from the cisterns. It can be done by a third ventriculostomy when you are approaching an ACOM aneurysm, or a lumbar drain or an external ventricular drain may be used. The next important surgical step is achieving proximal control. Proximal control is you want to decrease the flow into an aneurysm so that the aneurysm is softened, which will facilitate a more technically perfect and adequate clipping, and also prevent bleeds when the clip is being applied. In some cases, a single proximal clip is all that is required, like in an MCA aneurysm. In a PCOM aneurysm or in the posterior fossa in a pica aneurysm, even if you have proximal control, there will be backflow, which can result in a ruptured aneurysm, bleeding, and preventing an ideal clip. So here you can go for proximal and distal clips, temporary clips. In some aneurysms, you need to block two arteries, like both anterior cerebral arteries are communicating at the ACOM. So you put temporary clips on both the A1s before the aneurysm carrying ACOM segment. Usually what is done is the dominant A1 is clipped, the other opposite with a temporary clip, and the opposite A1 is identified and a small cottonoid kept. In case of an intraoperative rupture, then a temporary clip can be applied there. The problem with temporary clips is that you are depriving part of the brain from an oxygen supply, which might result in neurological damage. So this is limited by keeping the temporary clipping time low, and also by assessment of collateral flow. Motor evoke potentials have a role. I have not used it personally. Clip configuration, there are again some important laws. The first is you try to clip parallel to the parent vessel from which the aneurysm has originated. In some cases, like MCA aneurysms, you might need to reconstruct the arteries by multiple clips, stacked clips, which sort of obliterate the aneurysm and allow flow through the vessels. A quick look at some of the common aneurysms and to the individual challenges that they pose. Proximal ICA aneurysms, proximal control. Proximal ICA means usually ophthalmic segment or in the aneurysms in that region. Here, proximal control becomes difficult because there is no ICA often seen proximal to the aneurysm. And if an aneurysm is not controlled by a proximal clip and the aneurysm bleeds during surgery, you can have a disaster. So in these cases, the anterior clinoid is often drilled so that you get a segment of ICA proximal to the aneurysm where a clip can be applied. It is important to identify and preserve the ophthalmic branch. The clip here and in ACOM aneurysms should not fall back and compress or damage the optic nerve. In PCOM aneurysms, we already said there can be, you need sometimes two clips, one proximal and one distal. But even then, there can be a backflow through the PCOM from the posterior circulation. Very important that we protect the anterior choroidal, which has an origin very close to the PCOM. If a PCOM aneurysm has a bifid appearance, it might suggest that part of the aneurysm is projecting below the tentorium, in which case a small tentorial cut may be required to access the aneurysm safely. In case there is a fetal PCA, that is a posterior cerebral which is originating from the anterior circulation, special care has to be taken because here obliteration of the PCOM will be catastrophic. Laterally pointing aneurysms may rupture if you try to retract the temporal lobe. And another important thing is in a lateral pointing aneurysm, there may be pressure on the third nerve producing third nerve palsy. And after the aneurysm is clipped, puncturing and decompressing the aneurysm may help the third nerve to recover. ACOM or anterior communicating artery aneurysms are among the commonest. The concern is, we already discussed, that you need bilateral ACA control, even if one ACA seems to be very small or atretic on PSA, it often provides significant flow. And if you have a rupture, if you don't have both the ACAs under control, you can have a catastrophe. Both A1s and both A2s must be demonstrated before clipping is attempted. MCA bifurcation aneurysms may need multiple clips, and the common complication which I have encountered is that when you apply MCA aneurysm obliterating clips, you might tend to occlude the lumen of the M2, which can result in ischemia to the MCA territory, at least parts of the MCA territory. Pica aneurysms, difficult aneurysms to do, retromastoid versus more bone drilling. Proximal and distal control is necessary because if an aneurysm ruptures, even with proximal control, there can be torrential bleed. And the window to approach a pica aneurysm is between the lower cranial nerves. So you have to be very careful. Normally, the aneurysm clip applicator passes through one window, and you are seeing with the microscope through another window. Basilar tip, high riding, you can go by a pterional approach. This is a basic presentation on aneurysms just to orient the general community towards what a neurosurgeon can offer. The advent and evolution of endovascular techniques has reduced the number of aneurysm operations, and it has also eroded the skills for aneurysm clipping among neurosurgeons. Clipping has definite benefits. The cost is about 1/3 that of coiling. Clipping, the neurosurgeon is usually available around the clock and does not require a cath lab. There is an option of advanced techniques. Certain aneurysms cannot be obliterated without obliterating some vessels, in which case you can do a bypass. So anastomosis and bypass is a possibility during surgery. One advantage which we don't talk about much is that when you do surgery, you wash out the blood in the cisterns. This, in my personal experience, I feel has a definite impact on decreasing headache. It also most probably decreases the incidence of vasospasm. And in high-grade aneurysms, where there is brain swelling, the option of decompressive craniectomy along with aneurysm clipping could be life-saving.